But I must say I couldn't help sitting there, having just read Gail Wilson's book called As Texas Goes, So Goes the Nation, thinking about all of us being Texans. You know, there would be no commissioner up here making a talk, anything like that on any of these subjects, because for a long time we've made lots of sacrifices ourselves, and providers in this community have made lots of sacrifices themselves to cover the kind of population that both of you described. And now the federal government is finally stepping up and doing, you know, what it should be doing. And so I cannot imagine what it would be like to be a Texan. So I can't imagine what it would be like to be Manny, but the assistant commissioner, deputy commissioner, is here tonight from the Department of Commerce. And we've had a lot of conversations in the past in the healthcare reform arena that included the people that held the first two jobs. We haven't had a lot with the Commissioner of Insurance. But all I can say about that is it's about time, and we welcome your presentation.
So I have the wonderful job of explaining to you the wonderful and exciting world of insurance, and particularly the world of insurance in this new marketplace that the Commissioner Jessen has talked about called a health insurance exchange. Now, the first thing that when we use that word is that it's probably not going to be a word that's going to resonate much with your patients, your neighbors, your friends. An exchange at a conceptual level sounds like someplace you go to barter with people, right? You bring in your dirty laundry, you get something in return. That's not what we're trying to create. What we're trying to create, and as the commissioners indicated, is a choice the state had to do, was to decide whether or not we, the state, were going to create an online electronic marketplace for folks to be connected to that exciting product, health insurance. Now, if we didn't do that, our friends the feds said, that's okay, we'll do that for you. My sense from living in Minnesota now for 20 plus years is we don't like the feds doing things on our behalf, in part because they tend to steal our best ideas, and then we like to think they don't do so well with our really good ideas. So at the direction of the governor, he issued an executive order in October of last year directing first the creation of the Healthcare Reform Task Force, and then part of that directing my boss, Commissioner Rothman, to build this thing known as a health insurance exchange, to engage in the planning, design, and eventually implementation of this online marketplace. I'm pleased to announce that just this week we announced we just signed the contract for this IT solution that has to support this electronic marketplace. So let's start with that. An exchange is a place for consumers, employers to come to shop for products, to make selections among those products, and get enrolled in those products. It also is going to be, and this is unique, well, maybe not unique, but this is something Minnesota deliberately decided to do. It is also going to be our front-end engine to enroll people in Medicaid. So when I think of Commissioner Jessen, not only is she a wonderful colleague, she's also my largest customer. So we try to keep her and her agency very happy. Who are the folks who are going to come to the exchange? First of all, any individual can purchase an exchange. There are some criteria about, certain folks are not eligible, but for the most part, any Minnesotan can come to the exchange. Secondly, any small employer, 50 or smaller, that's the way we define small employer in Minnesota, is eligible to participate in our exchange and purchase insurance through there. We've done some estimations, some ballparking. If we do our job right and we're hitting on all cylinders, roughly 1.2 million Minnesotans will be accessing coverage through us. 700,000 of that 1.2 million will be Medicaid. Depending on what we decide with respect to basic health plan or whether or not we're going to do a wrap, there may be some implications for the folks who are going to be enrolled in commercial insurance products. But that's who we're talking about. 1 out of 5 Minnesotans are going to interact with us, with this marketplace. Now, being an English major, I tend to think in terms of analogies. I focus on the English major part because if I mention the lawyer part, I think you guys might turn me off. The English major part makes me think, so what could an exchange feel like? Well, there are 2 live exchanges right now out in the world. One is the Massachusetts Connector. So if you were so inclined, you could go in, put in a zip code from Boston, and you could see what that shopping experience feels like. I was at a presentation once where one of the panelist did a live demo. He pulled up the website on his laptop, and in 5 minutes, he had a quote. That's the kind of experience we're going to try to provide to consumers. On the other end of the spectrum, Utah has a different approach. They again have an electronic database, a website where you can go and shop, but it's focused just on small employers. So we're going to be doing both. We have to serve both individuals and small employers. We're going to be providing them information about plans. We're going to be getting information about their income, because as Commissioner Jessen pointed out, between 138 to 400% of federal poverty level, folks can be eligible for a tax credit to help pay for their coverage. So not only are we going to sell the product, we're going to give you low-cost financing to go get it too. That's going to be the experience we hope to provide. In order to get that work done, we've engaged in dialogue with a wide range of stakeholders, including members of the medical community, consumer groups, labor unions, Native American tribes, insurance companies, brokers, a range of folks who can give us some ideas, feedback, thinking about both the operational details of the exchange and some of the policy choices that an exchange may have to make. For example, an exchange can be housed in a couple of different places. It can be a state agency, it could be a hybrid, a public-private entity, and Minnesota has a lot of examples of those kind of entities, or a fully independent nonprofit. So that's a policy option that can be decided. Exchange can also make a decision about how selectively it wants to curate the product it sells. So there's the supermarket approach, right? You sell everything and people come in and make choices. Or there's the approach where you tell them, we only want to sell vanilla ice cream, so you guys had to come up with ways to differentiate your vanilla. Until we get a guidance, we're going to have to be in an environment where we're going to sell plans that meet the requirements the feds have articulated. And Commissioner Jessen has talked a little bit about some of those standards. First of all, the plans sold in exchange had to meet these minimum benefit requirements called essential health benefits. There are roughly 10 categories of benefits that plans have to meet. They have to be modeled on existing products today that are sold in a marketplace. The benchmark, if we don't make a choice, is the largest small group plans sold in Minnesota will be the benchmark for the essential health benefits. In addition to that, in order for a plan to be a qualified health plan, and that's a product sold in exchange, they have to meet certain network adequacy standards. Now, Minnesota happens to have existing ones. They apply to HMOs, but they serve as a good starting point for that dialogue on what a QHP network adequacy standard is. Plans have to be subject to quality metrics. That's going to be a fun dialogue for some of our carriers who have never had to participate in quality assessment. Plans finally also have to meet certain marketing standards, that they don't engage in marketing behavior that results in what we used to call in the insurance trade cherry picking, trying to market to folks who generate the lowest claims costs, otherwise known as young and healthy people. Now, some of that will change a little bit in 2014 because the exchange is going to be part of a broader marketplace where there's going to be things like guaranteed issue, community rating, risk adjustment between plans, things to mitigate the desire of plans to do what's in their economic self-interest, which is underwrite and sell to healthy, low claims folks. There should be hopefully less opportunity to do that. So where do they compete? Because plans are competitive, and having worked for a few of them, I fully recognize that behavior. But we hope they're going to compete on things like quality. We hope they're going to compete on things like value. That's the aspirational goal of creating this marketplace for consumers. It's to give consumers the ability to make selections aligned around quality and value, and do so in a way that gives them apples-to-apples comparisons, do so in a way that we've been directed. Your target is the best-in-class consumer experience. So when I think of the kind of customer experience we have to provide, my metrics are folks like Amazon, but maybe with a call center, because we have to provide a call center. those are the folks that I have to, that ease of use online, but then the ability to call someone up. Because after all, we're not selling shoes, we're selling something someone buys once a year, health insurance product. Couple of dates to have in mind that are going to be relevant as you think about the work that the exchange has to do. We have to be live by 1/1/2014. That means someone who comes to us has to be able to be enrolled in a plan effective January 1st, 2014. In order to do that, we have to be open for open enrollment October 1st of 2013. So don't be surprised if you start seeing outreach and marketing being conducted by whatever we call ourselves, because as I mentioned, exchange doesn't seem to resonate with people. We've done some market research, it confuses them. Sometime in spring or summer of next year. Prior to that, before we even get to do any of that fun stuff, Uncle Sam has to opine on our ability to actually pull this off. We have to file with them in November of this year our intent to proceed with a state-based exchange. Now, if we don't proceed with a state-based exchange, the feds will do something for us, or there can be some kind of combo platter. If we do some functions, they do some other ones. It's our conclusion that's a really, really less than optimal outcome. So we're doing our darndest to be sure that our friends at the Fed say, Minnesota, you guys go ahead. So that's November of this year. There's a lot of work between now and then. We have to continue getting stakeholder engagement and work. If you're not currently serving on a technical work group, you can follow that work on our website. You can certainly follow the work of our advisory task force. These are public meetings. If you ever forgot the way to stream them, maybe we'll do some kind of live streaming. But these are opportunities for people to provide us feedback about what would make this marketplace, this construct, this place for folks to get connected to the tax credit, to learn about plans, what would it make it valuable? Now, the one thing that, Commissioner Ellinger pointed out is that we're doing this framed in a construct of understanding that this is about reducing healthcare disparities. And I didn't quite understand, honestly, how we get there until I had a dialogue with someone who worked for me, and he reminded me why those of us at the exchange are doing this work. His wife happens to be an oncology pharmacist. She puts together the formulation to do the chemotherapy for patients. So this project manager of ours came home one day and said, hey, I'm working on this thing called the exchange, and he explained a little bit what it does. And she looked at him and said, well, you better get it done. And he's like, what are you talking about? He goes, do you know how much time I spend with folks who are not insured and don't have coverage to be sure that we can get them the care they need? If you can figure out a way to simplify that so we can take it as a given that folks are enrolled and are covered, I can actually spend more time in taking care of patients. And that helped clarify for me what we're trying to do. It's not about creating the coolest insurance marketplace in the country, though that would be a point of some pride. It is about providing an environment where the dialogue about eligibility is taken for granted. The paradigm that someone once explained to us as we were working on these exchanges, we're moving from an environment about not whether or not you're eligible, but to an environment where we figure out what you're eligible for. And that's what we are trying to focus on, is to create a way where the eligibility transaction is seamless, consumer-friendly, and hopefully works for Minnesotans, and in a way that gets people to care. So we can focus on those other things like quality and cost containment and not worry about access anymore. So with that, I look forward to taking your questions.